I really like the article I chose because I think it helps us view how we practice and how we change the way we practice because of the different kinds of research that we conduct.
And HIV is still something that is so heavily stigmatized inappropriately, but our populations, and it's misunderstood, and there's still a tremendous amount of bad information out there.
I do have patients who are actually still on older generation medications from 20, 25 years ago, but it's been working for them. And if it ain't broke, don't fix it, basically. It is the approach that the doctors take. If they haven't had many major side effects, they don't change it. So, we're in a very late generation sort of approach with PrEP and Descovy. And it will only get better as time goes on, and hopefully we won't need it anymore at some point.
Get ready for your unofficial dental hygiene podcast. These are the tales of two hygienists, one East Coast RDH and one West Coast hygienist. Listen as they tackle the profession of dental hygiene with humor and enthusiasm. Now, please join Michelle Strange and Andrew Johnston as they tell you a tale of two hygienists.
So, Andrew, I'm so excited that we are finally putting this together. We've been talking about engaging with the students for a very long time now.
Yeah, it's been a long time, and it's about time that we started really giving them the focus that they deserve, right? They're the future of our profession.
They really are. And we're excited that PDT has sponsored this episode because they do believe in the students being the future of our profession. They're going to be our colleagues, right?
Mm-hmm. You've heard about it in the past. We've been talking about PDT for a long time. They believe very much in quality education, and they've been sponsoring our episodes for a long time now.
Yes. And we think all of these episodes are actually going to be really great, even for the veteran hygienist. We really wanted to make these episodes and these roundtables focusing on topics that students are going to either be presented with when they go into new offices, maybe things that are happening during their time as a student. But, how do they go and move from student to new grad to experienced RDH?
Yeah, so we're expecting to have episodes. Sometimes it'll be on instrumentation, how to adapt to certain angles, using an ultrasonic, maybe sharpening the instruments. And then other times we're going to talk about what types of offices that you're going to encounter, whether it's corporate, private practice, maybe a DSO. We'll talk about pay structures. There's just so much that's out there that you're right. Even the veteran hygienist is going to need to know these things as well.
And so we hope you enjoy this episode, and be sure to check out PDT, your Paradise Dental Technologies, because they have some of the greatest instruments.
Hey, Michelle.
Yeah?
It's time for the interview.
Oh, but I had something else to say.
We need to let the experts talk now.
Fine. So listeners, especially students, new grads, or those to become dental hygiene students, please welcome a few of my guests to this new series in 2020. I'm really excited that you guys are the ones here to kick it off with me. But we're switching up that student-focused roundtable, and it just being kind of anecdotal experiences or, some great advice. We really want to make sure that we are all thinking critically and using the most current science. And so we're going to appraise some articles. So welcome Daniel, Amber, and JoAnn. Thank you so much for taking the time to come on.
Thank you, Michelle.
Hi, Michelle.
Hello.
So I do want to take just a few seconds from each of you and explain who you are, what you're doing, and why this topic was relevant to you. So I'll start with Daniel because you're in my view up top.
All right, so I'm Daniel Lopez. I've been a hygienist since 2012. And immediately upon graduating, I've been working in the same clinic, Calnord Community Health Center, which is an HIV, LGBTQ focused clinic in metro area of Manhattan. And my clinic has been in existence we actually just celebrated our 50th year. So, we started with the Stonewall riots, and then with the HIV crisis, we were kind of like a little hodgepodge of scattered clinics and programs, and eventually coalesced into what it is now, which is a full FQHC that includes medical, dental, social, behavioral, community outreach programs across the entire health spectrum. So we're pretty much the future model of what healthcare is trying to shift towards. And so that's where I've been focusing on my work.
Awesome. Amber. Welcome back. Everyone has been on the podcast too already, but welcome back, Amber.
Thanks. My name is Amber Riley. I have been a dental hygienist for upcoming on 22 years now. I've generally practiced in private practice. I live in San Diego, California now. I've been in Southern California for 11 years. I've been in San Diego for 5 years. I'm in a suburban dental practice with 2 general dentists. I have a small population that is either HIV positive or on PrEP. And that is the area that my article is actually focused on that we'll discuss here in a little bit. But it's HIV and the language that has changed just since I've been a clinician, that we're no longer dying from AIDS or dying from HIV, but we're living with an HIV positive status. Just in the 20 few years that I have been a clinician, it has been such a remarkable amount of effort focused to this particular virus. It's amazing to me. So I'm very appreciative to be included in this group, and I will learn from each of you as well.
I know it's going to be fun. And last but never least, Miss JoAnn Gurenlian, welcome back.
Thank you, Michelle. My name is JoAnn Gurenlian. I have been a dental hygienist for 40 years, so I'm the old member of the group, but feeling very young and energetic. I am the graduate program director at Idaho State University, but I live and work that position from my hometown in New Jersey. I have been teaching pathology almost all my life. And in the 80s, when we actually recognized HIV disease and AIDS, I was on a task force in Philadelphia to address this problem. And we first started looking at all the different challenges associated with this condition. And really, we're babies thinking about how do we address this and how do we prevent this disease. And so it's remarkable to me that, in much of my career, we are still looking at the challenges of preventing this disease. So my article, too, like Amber's, talks about PrEP. And we'll talk about what that word really means. And the article I chose was actually a qualitative study. And what does that mean? Because I also teach research. And so since we're working with students, I look forward to talking about what are different kinds of research and how do we allow that to influence the way that we practice. And I really like the article I chose because I think it helps us view how we practice and how we change the way we practice because of the different kinds of research that we conduct.
Love it. So if you haven't caught on already, this topic is going to be on HIV and immune compromised patients. And, the reason that I wanted to take this out of the gate, January 2020, was because of the article Jasmine Haley posted that a lot of people were still under the misconception that you could hug somebody and get HIV, or that saliva was actually going to give you HIV. So I like to tackle the elephant in the room and really kind of hit things, head on. So I want to really have a good conversation about that and really look at the research. And, Daniel and I get real frustrated with Facebook sometimes seeing the, can't use ultrasonics on those patients. And this just, the eye roll was strong on that one from all of you. And it's a very common thing that we hear, unfortunately, even in 2019, 2020. So I think we're going to take each one of one of your articles and we're going to appraise it and then ask questions about it. And I think both JoAnn and Amber have something on PrEP. So I might start and bookend you guys with that topic. So any particular one of you want to go first?
I'll start, and then feel free, Daniel and Amber, to jump in if I'm saying something that resonates with you as well, because this is a team approach to our topic. The article I selected was from AIDS Care, and the title is PrEP and Sexual Wellbeing, a qualitative study on PrEP, sexuality of MSM, and patient-provider relationships. And the authors are Devarajan, Sales, Hunt, and Komu, and I may be mispronouncing someone's name, and forgive me for that because I'm terrible at names. This is a 2019 article. The article starts off by talking about the fact that in 2017, men who have sex with men, and that's MSM for the students who may be wondering, what is the language we're talking about? That accounted for 66% of all diagnoses of HIV among adults and adolescents in the United States. And in the U.S., one of the things that they're working towards is, trying to change some of those statistics with prevention. And in the U.S., in particular, Georgia has the second highest rate of HIV incidence. And so they were targeting 4 counties in Atlanta to try to investigate, why is everything so high in that particular state? And so let me just mention that a qualitative study is where you do interviews or focus groups to try to capture what is a better understanding of what is happening versus doing a quantitative study, which is where you might do a survey of people. And sometimes on surveys, people are quick to do responses, but you may not always get an in-depth understanding of a phenomenon or what is happening in something. So in this case, the researchers were trying to understand a little bit more about what is happening with men who have sex with men and their sexual health and their sexual behaviors. And the PrEP part, again, because this may be language that students are not understanding, is a pre-exposure prophylaxis. So again, I'm fumbling over my own words here. And what does that mean? There are 2 medications that can be used that individuals can take who are looking to prevent the exposure to HIV disease. Now, you're probably thinking, well, that's only men who have sex with men, but that is not true, actually. It can be men who have sex with men, but it can also be heterosexual individuals who might have an HIV positive partner or may have multiple partners, and they're trying to prevent their increased risk of contracting HIV disease. Or this can also be individuals who inject drugs and want to reduce their risk of contracting HIV disease. So for anyone who feels that their risk exposure can be high, this is a preventive procedure. As part of that procedure, when they go to a healthcare provider and say, I want to have one or the other of these drugs, they then have to follow a regimen where they see their healthcare provider to have the prescription every 3 months. They are recommended to follow best practices, use condoms, that kind of thing, and get tested for sexually transmitted infections on a regular basis. So that's a protocol that's followed. The 2 drugs for PrEP are Truvada and Descovy. And I may not be pronouncing them right, so Daniel, jump in if I'm not.
You're A+.
But okay, yay. So anyway, that's a little background on it. So what was the study about? So the study was interviews of 20 men who have sex with men. And the interviews are open-ended questions. They call it like a semi-structured interview, which is where you ask questions of an individual and you probe to find out more information. But it's semi-structured in that the questions are made ahead of time. And typically, the individuals who are participating have an opportunity to see the questions ahead of time so that they can think about their answers and not just answer, oh, yes or no, but really give thoughtful answers and provide as much detail as possible to their questions. So they have inclusion criteria. So how do you qualify for this? Well, they had to be men who have sex with men. They had to be between the ages of 18 and 60. They had to reside in the Atlanta metropolitan area, and they had to be prescribed PrEP for the last 3 years. And as an incentive to participate, they were offered a $10 gift card for their participation. So $10 doesn't sound like a lot to me. I know when my grad students do research and they do a qualitative study, they're handing out, Amazon gift cards left and right, and they're usually a bit higher than that. But anyway, that was the study. The primary investigator was actually a woman who was trained as a public health researcher and had experience working with the LGBTQ community. So some may say, well, why wouldn't they have picked a man for this? But apparently she was very experienced in doing qualitative research and very open in the way that she would engage people and have people answer and talk to her. So apparently she's very effective at what she does because she was able to get a lot of great responses to the questions. So anyway, the questioning went on anywhere from 28 to 72 minutes. On average, 41 minutes was the length of an interview. And that's overall in qualitative research. That's a pretty substantive interview to have. So overall, again, I said there were 20 individuals. Most of the individuals openly described themselves as gay men. 15 of the men identified themselves as Black or African American. The average age was 30 years. Most of them were college graduates, many of them had master's degrees. Half of the participants were in a romantic relationship at the time of the interview and considered themselves to be single. So I thought that was interesting. And most of them were on a PrEP regimen and had been so for quite some time. So that's a little bit about the individuals who participated in the study. And I'll give you just a brief overview of the findings, the key findings. So what the men said who participated in the study is that participating in a PrEP regimen gave them reduced feelings of anxiety about their sexual experience and a reduced feeling of being stigmatized about being a gay man who has sex with men. And they felt that they had more open communication and dialogue with their healthcare provider. So that was something that was very important to them. They could talk about the kind of medications that they were taking about. They could talk about sexual practices that they had. They could talk about being compliant with their prescription regimens that they were on. They could talk about positions that they had with their partners. And they felt that they had a better relationship and rapport with their provider overall. There were times where some of them talked about certain providers they had better experiences with. So if I sum this up, the short version, some individuals felt that they had a better relationship if their provider also was gay, which I thought was really interesting. But they said that if their provider was gay, their provider could understand more of their experiences. Not that they couldn't talk with somebody who was heterosexual, but a person who was homosexual understood more of their experience than a provider who was not. And sometimes they felt that if their provider was not homosexual, they sometimes judged them or felt they were judging them. And that may have influenced their ability to answer honestly or to be compliant with the recommendations. And they felt that some providers who were not homosexual tended to follow a script when taking a sexual history, which made them feel, even if they could answer honestly, made them feel that they should not be as open about their answers. So if I'm going to take this down to the discussion part of the article, which I thought was really fabulous, the authors talked about the idea that we needed a shift in our sexual health framework of medical care. I love the language of that, a shift in our sexual health framework in medical care, and that we needed to move away from how we stigmatize what we do surrounding sex, and that we needed to unite the medical fields in reproductive health, infectious disease, and primary care to maximize sexual health promotion. And that we needed to be able to talk with our patients more openly about their sexual experiences, their sexual desires, their behaviors, their pleasure, their risk-taking, but not make it seem so judgmental when we talk about risk, because we might close a discussion and an opportunity because we talk about risk in a negative way, and we need to find a way to talk about risk in a positive way. And so they talk about integrating sexual health frameworks in provider training and practices so that we as healthcare providers get more experience and exposure in this arena, so that we are lessening the opportunity or lessening our practice of stigmatizing things and having more positive exposures and experiences for our patients. And the other thing that they talked about, which I thought was just so great, was the idea of using cultural humility and different frameworks when we're talking with our patients, because, look at us, who we are and the different kinds of patients that we will see in our practices, and how we have to think differently in the way that we approach our patients. And, how we address this makes a world of difference for the way our patients view themselves and how we view them in what we practice. So if I were to give a takeaway from this great study, is that when we are working in our practices, we take what we think is a health history, and our health history isn't nearly as comprehensive as it needs to be. We need to be comfortable taking a sexual history as part of our health history. That is, or should be, part of our health history. And we need to be able to learn how to do that, without stigmatizing, without judgment, allowing our patients to be free to be honest, and with being encouraging and promoting prevention, because we are preventive specialists. So that's my bottom line, and I'll turn it over to our other great speakers to offer their information and then answer questions as they come forward.
Wow, that was great. I feel like, Daniel, this is kind of what you're practicing, right?
Yeah, so in a perfect world, it wouldn't matter who the provider is, right? We would want our patients to come in. We would want them to be completely honest with us, but that's just not reality. People are stigmatized all across the spectrum for any number of reasons, and it may be a very subconscious thing, but, if you don't look like them, if you don't sound like them, if you don't know where they're coming from, if you don't understand their background, you're not going to get 100% of their story. You're not going to get 100% of their health history, their picture, their practices, nothing. You will never, ever do it unless that patient has full confidence that they're not going to be judged by you, or that they can speak freely without without even the illusion of you scribbling something down as oh my God, is that going to go on my medical record? Is that going to, what are you thinking of me? It's probably never going to exist. We're never going to be there, which is why diversity in our field is so important, and right now is so very lacking. I believe we're one of the least, if not the least, diverse, larger medical professions in this country. It's
so true. Amber, did you have any thoughts on that?
I'm nodding in agreement, as you can see on the video, but with what JoAnn mentioned about our medical histories generally being grossly inadequate in average practice, I couldn't agree more. I have an entire 3-hour CE course just on taking a medical history. And sexual health is part of our medical history. And sexual health is absolutely demonstrated in the oral cavity. But her takeaways from the article are outstanding, because there is a way that we have to relearn how to ask questions and relearn how to reposture ourselves so we're not projecting a judgmental or and even an inadvertently stigmatizing comment. And like what Daniel was saying about even just writing a note down real quick in the chart or on a Post-it note or something, there's a perception that can be unfortunately absorbed by our patients, and just being cognizant of that. And HIV is still something that is so heavily stigmatized inappropriately, but in our populations, and it's misunderstood, and there's still a tremendous amount of bad information out there. Great discussion already.
Yeah, I agree. So some of the questions that kept coming back to me, I'm curious, how long has PrEP been around?
PrEP has probably been around, I would say in general, like in a large sort of output, probably since about 2010, 11, but I'm not exactly sure about that.
Okay, so
And it
a
was
decent
shortly
amount of
after I
time,
started
not
working.
this year. So it
No.
should be something that we are all very well versed in. Should be the key word there. And I'm curious, what is that health history? How does it sound like if we were to have that conversation? Because, I'm 15 years as a hygienist now, and I had to have my very first conversation about sexually transmitted diseases only a few years ago, probably because it was so blatant and it was with a bunch of medical providers. So they were like, oh, just have this conversation. It wasn't me like sending them to, they were in the building with me and they're like, just have this conversation. I'm like, but what? No, that's your job. No, that's you have that conversation. But they're like, no, like your healthcare provider have it. And I was like, oh, this is so uncomfortable. But it's a great time to just kind of look internally and be like, why is this uncomfortable? It shouldn't be that uncomfortable, and get right with it and then have that conversation. So I'm curious though, for our students, for someone that has never had this conversation or asked the questions on a health history, I mean, what would that sound like?
In my experience, like I said, we went over before, this is my population. My clinic has 20,000 patients and about 80% of them are HIV positive. In the dental clinic, I have about 9,000, 75, 80% HIV positive. So this is every day. And I can't tell you that there's one good way to really start it. I generally do my EO/IO first, and I look for signs. Like, does something look abnormal? Do they seem to be at a certain sort of risk? And then I kind of go from there, because I can tell them, hey, you know what? You seem to have like a lot of inflammation, and you complain about it, scratchiness and whatnot, or redness at the back of your throat. Have you been having sex with someone that you're not familiar with recently? Did you have a hookup? Are you in a relationship? Are you monogamous? Is your partner experiencing this? So you kind of just have these little questions and kind of just go and branch out from there. The way they're most comfortable with it is if you link it to something that you can already see or explain.
Okay. That's a good way to do it. And so if I were to see those two medications on a health history, any thoughts on like what my follow-up question would be?
When I have a patient, new patient, existing patient, regardless, that has indicated either they've written on their health history form update that these medications are now part of their protocol, or just when I'm having a one-on-one discussion privately in my operatory with the patient, my follow-up question first is how long? And did you have an HIV status blood test prior to going on, which they are supposed to have a negative status before going on. But I've actually been reading that there is kind of a black market in the United States for PrEP. And so you can get anything on the black market. And so by asking, did they have an HIV test prior to receiving the prescription, I want to know who prescribed it. And then they said that they had an HIV test before starting the protocol, then ideally I should assume that they're under a physician or nurse practitioner supervision and that they're receiving the medication appropriately. And then what's the name of your pharmacist, or who's the name of the physician or nurse practitioner that's prescribing the medication? That's just good medical history there. But my first question is, how long have you been on it? And then so I know that your status is negative. And then it's a conversation about encouragement and support. And I recognize the significant responsibility that they're taking for themselves, whether it's just that they have a relationship in which one partner is positive and one isn't, or they just have a higher exposure lifestyle, either through intravenous drug use. Heterosexuals, homosexuals, I have males and females in my practice on PrEP. I have gay and straight in my practice on PrEP. And so it's not just one population.
Thank you for reminding us all of that. And is this medication indefinitely, or is there they need to stop or go back on? How does that work?
My understanding is that it is a long-term protocol. However, it's such a new drug. I believe it was 2014. I believe it got FDA approval in 2014 or 2013. But then they will stratify the populations for which it's approved for. So it didn't just get a blanket approval for everybody. They stratified the approvals for men having sex with men, and then sex workers, and then blah, 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 blah. What was the question again?
I was just curious, how long could you be on it indefinitely?
I actually just had this conversation with a patient of mine a couple of weeks ago, and he's been on PrEP for a couple of years. And he's looking forward to going off of PrEP because he is in a monogamous relationship now. Because it's such a newer drug, we have not seen yet the long-term deleterious effects, if any, of being on this medication, liver, kidney metabolism, things like that. What I see as a clinician on my patients with PrEP consistently is that I see breakthrough bleeding. Are you treating any patients? Do you see that, David or Daniel, excuse me?
Not really, no.
That's something that I've seen almost every single one of my patients. I see no obvious signs of inflammation, but just more friable tissue, breakthrough bleeding. And I was having the discussion with a periodontist outside of Chicago, actually, and we were discussing the same thing. And we do believe that is related to the liver metabolism of the drug, and that there is a reduction in clotting factors after extended use. But the research is ongoing.
Yeah. Are there any other side effects like dry mouth? Obviously what you just said is a pretty decent side effect, or something that we just need to be aware of. Anything else?
Well, we've seen, I think, because my doctor has recommended PrEP for me, I've been wishy-washy and going back, taking it. But he says, my doctor is a gay men's health specialist. He's been working in the field for the past 20 years. Long-term effects the expected ones are 1% to 2% loss in bone mineral density. That's the more likely will happen side effect. But as far as, other potential side effects, it's mostly the tenofovir in PrEP that is the biggest culprit in bone mineral density. But every generation, it gets better. Every generation is less toxic than the last. And I believe Descovy is even better at this point than Truvada is, as far as long-term side effects, bone mineral density loss. But the current HIV meds that are out there are pretty lax compared to what they used to be. I do have patients who are actually still on older generation medications from 20, 25 years ago, but it's been working for them. And if it ain't broke, don't fix it, basically. It is the approach that the doctors take. If they haven't had many major side effects, they don't change it. So we're in a very late generation sort of approach with PrEP and Descovy, and it will only get better as time goes on, and hopefully we won't need it anymore at some point.
That'd be great.
Exactly.
Thank you so much, JoAnn, for bringing that article to us. And
I do have one thing. Sorry, to answer your specific question, generally the doctors in my clinic recommend it. PrEP is not something that you take for a lifetime. They'll take it when you're going to be sexually active, high periods of sexual activity in your lifetime. Are you in an open relationship? Are you young? Are you, in the metro area, always at the bars and clubs? That's what they're really targeting. And they tell them, no, it's not really a lifetime thing. And there is also, are you familiar with PrEP on Demand?
No.
No,
any of you? So you can look up the IPERGAY study. I believe it's the IPERGAY study that was done in London. And they found, and actually doctors are recommending this now, that if you take PrEP in expectation of having sex, so the regimen is you take 2 pills the day before, 1 the day of, and 1 the day after, is as effective as taking PrEP every single day. So that has been cleared by the FDA, and it is effective, and people do that and actually find that they have better retention with it because they don't feel like they have to take it every day and doesn't become a sort of burden on them. And, it opens up options.
Thank you for that.
Mm-hmm.
So what article did you bring to us today, Daniel?
So mine isn't directly about dental care in regards to HIV patients, but it's from the American Journal of Public Health in 2018. The title is The Influence of Housing Status on the HIV Continuum of Care, results from a multi-site study of patient navigation models to build a medical home for people living with HIV experiencing homelessness. So I really wanted to put a note on the things that we're not trained for that impact our patients the most. And I don't believe any hygienists come out of school ready to have a conversation about housing status, homelessness, and all of the risks and detriments that come along with having unstable housing. It is one of the highest determining factors in someone's HIV risk. I believe, especially when it comes to MSM, especially MSM of color, there are far higher rates of homelessness, and their disease risk is just incredibly higher than someone who has stable housing, stable employment, and everything we would hope and dream for. I'm not going to go too much into the numbers on this because this is a lot of it's no-brainer. Like, if you have stable housing, you have less pressure, you have less stress, you typically have more money, and you typically have a medical home or a doctor, and so you don't have all these distracting factors in your life that inhibit you from taking care of yourself. But one of the key things in this article is that it talks about patient navigators. Are you all aware of patient navigators?
But will you define that for our...
Yeah. Sorry, yeah. I'm not just talking to you for it. That's right. So patient navigators are a fixture of community health centers. It's usually an entire department, and they have one-on-one cases with people where they pretty much walk them through life, as far as making sure they have a doctor, they have a medical home, they have a mental health therapist, that their rent is being paid, that they are on food stamps if they're eligible. They pretty much guide them through every single thing that will lead them to stable housing and stable health. And in my clinic, since we have the dental clinic right there, they also guide their patients to the dental clinic. So we'll have patients in an LC on their chart that they have unstable housing, and like, oh, have you seen your patient navigator lately? What's going on? Because I think what's happening in your life is distracting you from being able to pay attention to this, to floss every day, to do all these little things that you could be doing. But when you're juggling so many things, when you're not sure where you're going to sleep at night, when you're not sure if you're going to still have a home today, tomorrow, or if you're one missed paycheck away from being evicted from your house, all of this prevents you from taking care of yourself across the entire medical spectrum. And that is one thing that we can really, really start looking into, even in private practice, because it's a pretty straightforward question. Is your housing stable? Are you able to pay your rent? I see that you're showing signs of stress. You have incredibly inflamed gums when there's no other reason. Hygiene seems pretty good, but you still have all this inflammation. What else is going on in your life? And opening up that conversation and knowing that there are people that you can refer them to in these health navigators, in these health homes, is really, really instrumental in holistic care and making sure that you kind of crossing your T's, dotting your I's on what else can I do for this patient.
Very nice. Was there any conclusions or little tidbits for the maybe students or listeners that you would love to bring up?
So this study focused on about 700 people from different backgrounds all across the country that were in health homes, and they found that they had at least, about 10% higher chance of becoming virally suppressed, which is when you're adherent to your regimen and the antiretroviral therapy, and all things being fairly stable, you can suppress the virus to a point that it's not communicable one way, even without protection, even without PrEP. If someone is virally suppressed, there are no documented cases of them transmitting the virus, and that is the ultimate goal of therapy on somebody who is HIV positive. And they found that once they introduced these either unstable or directly homeless people to a patient navigator, and they were able to get things relatively stabilized, that their viral suppression rates went up, the adherence to their regimen actually was more stable, and they were able to get see their doctors, and to see their dentists, and to see their mental health therapists. So housing is, I can't stress how important it is to just even throw out a simple probing question, are you stable at home? How much of an impact that can have on different people.
That's a great reminder, and across so many areas, right? Any questions from you ladies first?
What drew you to this particular article? What kind of caught your eye?
See, this is more of an experiential thing. I feel like there's so much that can't be defined by studies. There's so much that can't be defined by, looking up a paper. You have to be in it to know it. And in New York City, we're having kind of a burgeoning housing crisis where even like a median income is not enough to live by yourself. And if you're on the low spectrum of, annual income, if you have unstable housing, there's really there's very few options. You might have seen in the news lately that New York has been like quote unquote shipping people who are either homeless or have unstable housing to other states. And it's true. They've been giving them about 1 year's worth of housing rent assistance to move somewhere else, just trying to start over. And I mean, that program's a little controversial, but it serves to highlight what we have going on here. And I find that my patients who are in unstable housing, who have very low or unstable income and are at risk of losing their homes, are usually the ones that experience the highest stress and have the highest dental presentations as far as uncontrolled bleeding, or just unfocused home care. It's becoming endemic to our city, and I don't know what more we can do as far as addressing it, except for trying to get people in to see patient navigators or some sort of civic support system.
And there's a myriad of pathophysiology that follows that stress too. The hypertension increases, lack of sleep, when then there's diminished oral stability on top of that as well. Stress-induced
immunosuppression,
Not to mention food insecurity, and then your nutrition is compromised, and then your health is compromised. So there's a whole host of things. There's a cascade that follows. So I think this is a great way to help students and new practitioners appreciate that there's more to that health history than how are you feeling today and has your health changed since we saw you last. So I think we have to really broaden our view of our patients.
Well, it also brings back is it Haslow's hierarchy of needs? What?
Yes. Havlov's? No.
Maslow. Maslow.
Thank you.
Maslow.
Thank you. Because I can remember learning that as a student RDH and thinking, can we just get to the scaling? Can we just get there already? And now looking back on that, I mean, I don't think you should put a scaler in hand until you really understand what that means to you have all these insecurities. And if you can't find a place to lay your head and find food, a toothbrush is just not the biggest thing in your life. Just really isn't. So thank you for that.
Yeah, one of the findings of the study is a lot of people reported, I actually have a few studies that I brought that were kind of related to this. This is just the core one that I liked. They examined teenagers and adolescents who have unstable housing, and about 40% of them reported that they don't brush because they don't have a place to brush.
Yeah.
Thank you for reminding of that as well, because I think we lose sight of that sometimes. And JoAnn, you made a great point that it's more about asking any new surgeries, any new medications. There's a lot more to that health history. So thank you for that, Daniel. Amber.
All right. Well, to bring it all home, my article was also, it possibly is the same publication that JoAnn's was from. It's AIDS Patient Care and STDs is the topic of the journal. This was published just in November of 2019. The title is Perceptions of HIV Pre-Exposure Prophylaxis Among Young Pregnant Women, but it's from a rural area of South Africa. But I was drawn to it because of probably the least group of users on what would be at least a Western radar would be young heterosexual females, assuming heterosexual given the fact that they're pregnant. And so for the students that are listening, the first things that I always do when I look at a study is, I want to see when it was published and where it was published. I want to know if this is a peer-reviewed article. And then I look at the authors and what the authors' affiliations are. These authors are Leah Vasquez, MD, and she is with the Bridgeport Hospital of Internal Medicine in Connecticut. Anthony Mole with the Church of Scotland Hospital in South Africa. Alexa Kaysen with Northeastern University in Boston. Netombi Ndlovu, the last name is spelled Ndlovu, and she is also with Tuegla Ferry, South Africa. and then Sheila Shenoy, and she is with the AIDS Program Department of Medicine at the Yale University School of Medicine in New Haven. So I look at the authors, I look at the title, and then you can get into, if you're moving into research, like JoAnn talked about, what a qualitative study is versus quantitative study, and the differences in the way those are designed. I believe, as I went through this, and JoAnn would be the one to confirm or correct me, that this particular study that I brought to the table was based on multiple, they referred to him as an interview, but they've included the questionnaire. So it was really more of a questionnaire type of a study. So I would say that that's a quantitative study, if that is correct, JoAnn, based on this. But these are young women, and then I wanted to know what's young to these authors, and the mean age was 20.3 years. So yes, that is very young. It spoke briefly about what oral pre-exposure prophylaxis is, which is PrEP, gave the drug names tenofovir and tenofovir alone or possibly in combination with TDF-FTC, which is emtricitabine. That's a hard one. Thank you. I know. The World Health Organization released a technical brief in 2015 that recommended pre-exposure prophylaxis to all persons of substantial risk of HIV infection. So a substantial risk group was considered an incidence of 3 per 100 persons or higher. There was very little data that the authors found that was available on PrEP during pregnancy and breastfeeding, which is the focus of this particular population study. However, there was also no significant differences in maternal or infant outcomes between women receiving PrEP or a placebo at the time of conception. What I found interesting, and going back again to JoAnn's article, she spoke about cultural humility when we're just talking to our patients. And even though this is a population of a significantly impoverished population, they have one of the highest HIV contraction rates, especially among heterosexual women in the world. Truvada was approved for PrEP or as PrEP in South Africa in December of 2015. And it was only for men who have sex with men and sex workers. And that is it. And it was available only in selected locations. There were 187 young, which again, the mean age was 20.3 there, pregnant women that were interviewed. Some of the questions were on HIV knowledge and HIV risk. Some of the questions included, do you believe that HIV can be acquired through unprotected sex with a person who has HIV? Do you believe that HIV can be transmitted through breast milk? Do you believe that an HIV positive mother can give her child HIV? What's your understanding of condom use? How frequently are you using a condom? If your sex partner doesn't want to use a condom, is there anything you can do about it? Things like that. Not a single female in the study population had heard about PrEP before this interview, not one of them. But 97% of them after this interview were very interested in taking PrEP. And then in this article, and we'll have that in the link for the podcast, it includes all of the questions and what the percentage of yes numbers were out of all of them. There were some obstacles that the authors identified to this implementation, especially among the young pregnant women or just early postpartum. Would they be hesitant to take the medication if there was not 100% efficacy to prevent infection? There was a concern about if they were taking PrEP that they would be immediately mistaken as being HIV positive. That was over half of the population that was concerned that if they were known to be taking this medication, that there would be a stigma attached to it, that they would also be recognized then as HIV positive, which in this culture then would make them unmarriable and would lower their status significantly. Most felt that their family would support them taking PrEP, but most also felt that they would have risk compensation, meaning if they were taking PrEP, then their likelihood of implementing consistent condom use would go way down. That's for the students listening, the term risk compensation means if I'm padding my bets in another way, that I'll slack off on other ways of protecting myself. That not more is more, but that less is. If one is possibly better than another, then I will compensate this reduced risk by eliminating another known behavior of safe practice. Overall, the results of this study, this is the author's language, quote, suggest that young pregnant women are cognizant of their HIV risk and express interest in protecting themselves, but they experience an inability to do so using traditional methods. But the potentially major obstacle was a perception of HIV stigma. In this rural, impoverished region, there is widespread knowledge of HIV transmission through sex, and there is a broad understanding that condoms have a preventive role, but it still didn't translate into high levels of condom use. That women in this population have a significantly lower status in the society, and they, where was it here? Despite the concern of women about HIV infection and recognition of the risk of acquisition from current sexual partners, part of the paradox may be explained by the common practice of transactional sex, and that doesn't necessarily mean prostitution, and also age-discordant relationships. Both phenomena amplify the power imbalances and intimate partner violence that is already present in heterosexual relationships that limit women's agency to negotiate safe sex, and it increases their risk of HIV acquisition. There was a little bit of hesitancy due to long queues at the health clinics to be able to pick up the drug. Some concern about its overall effectiveness. There is some hesitancy as to the true efficacy of the medications, and those are some barriers. But this translating into patient care, translating even across the globe, is that no matter how much education that we can provide to our patients, but to the public at large, the implementation is going to have to be coming from their self-motivation. And they did see a big shift between young, single, non-pregnant women and the women that were pregnant. That seemed that click of pregnancy tended to turn them into a much more prevention-focused medical consumer, if you want to call it that. But this was not quite the article I thought it was going to be when I finally got a hold of it. But as I read it and really kind of dug into the data a little bit more, I found it to be pretty interesting because it's definitely an underserved study population when it comes to medications. But young heterosexual females tend to be the bottom of the rung when it comes to drug trials and populations of understanding health IQ. And it's a low risk population, but in this particular area of the world, it's not at all. It's a very high risk population. And so, do you have any questions about that or any thoughts? Does it bring anything to mind to the panel?
I'm just happy for the global perspective because we do have a global audience. So, and I do also appreciate you explaining how you choose your articles to sit down and appraise and read, because I think that's very important. Anything from you guys?
I find it really interesting, their outlook on their hesitance to take, PrEP because their family might assume, or the stigma, Michelle and I have both gone to Uganda where they have, and we saw health campaigns that they have there. In school, they teach the kids, support your peers, help your peers who are living with HIV. They're just like you, they're your brothers and your sisters. But, we can't be sure, is that effective? Is that actually helping, reduce the stigma that they face? Because clearly there's still a problem there. People still believe that they are of lesser status, or, when, even for just taking PrEP, it might be seen as a scarlet letter. Like it's a sign that, oh, she's taking that. She must be.
Or that she's promiscuous because she's on, PrEP, which is, like the scarlet A.
Yeah. And that actually stuck with me too, because I think the very common misconception is that people are out there just living a crazy lifestyle, slutting it up. Like that's not the case. Like abuse and people can contract HIV in so many other ways. So you can't assume anything ever.
There was a discussion in this article looking at other methods of delivery of the drug. They've not been developed yet, but would there be a greater consistent use in at-risk populations for women if this drug were to be able to be delivered, say, with a vaginal ring versus a pill? Something that could be taken and held discreetly, changed once a month or every 3 months, even an injectable versus standing in line every month for your prescription of pills. To clarify to the audience, these are not methods that are available currently, but it was a discussion point from the authors of this article that could this be something to consider that would increase the use and consistency of these, what we see to be extremely effective drug modalities.
JoAnn, did you have a point to make?
Just that it's really remarkable that a study was done on women who are pregnant, because that is not typical.
Like an IRB. Yeah.
To get an approval to do a study of women who are pregnant. So the fact that, for students to understand that it is rare to see that kind of study done, it's exciting to see that was done. So to share that with our students.
Excellent point.
Really great. And I too appreciate the fact of how you go about looking at an article to decide what would be an appropriate article to review, or, something that students will learn when they're taking a research course is that there's quality research and then there's not so great research either. And you have to learn to be discerning about what is good research in the scientific literature, because you will find a lot of information out there, just like you see information on the news and you'll see information on Facebook or social media. And that doesn't mean because you see it that it is true or that it is appropriate. Learning to be discerning about what you see and what you read is going to be an important skill set for you to learn. And my last little piece is that just before this podcast came up, there was a little blurb, an abstract that came out that there is now an implantable PrEP that is being tested. So it's Amber, you're like right on the cutting edge here. That is being tested. So we won't know more about that yet. It is being tested. It's in a controlled phase 1 trial, that's looking at a year-long contraceptive, or it's a concentration, about looking at it to see. The idea is that it could be used for a year. It's in trial now, being used for different periods of time to see how effective it would be. So stay tuned on that, because it is going to come out. I feel that it probably will get FDA approval for a year-long availability. So it should be something that we can all look forward to. And so that's the other beauty of staying in tune with research, because we go to research meetings so that we can learn about these discoveries. And then in our lifetime, we see them come to fruition. So one thing that's used, it's a drug, and somebody might take that drug for a period of time. And the next thing we know, it's something that could be an implanted device. And then the patient doesn't have to take the drug, and they may not have the side effects of taking a pill. And who knows what the next generation may be. And that's why you want to stay invested in research and learn about it and read about it, because things change all the time. And you want to be a discoverer, and you want to be a part of that process.
Thank you for saying that. My one last question to all of you is, I am curious, if you see a patient in your chair that has HIV, what changes for you as a clinician?
Nothing changes for me as, do you mean like my SOPs, my infection control protocols? And no, nothing. I treat every patient exactly the same, regardless of any immunological or infectious disease state. I think some patients, I'm much more cautious with the diabetic patient because they're much more periodontally fragile than an immunocompromised patients. And patients with RA are probably on about the same parallel with an HIV positive patient because they're both usually on immunosuppressants, if not antivirals. So no change for me.
Daniel, are you about the same?
The only change, and I put that in quotation marks, is if I see a presentation, if I see something that might seem to be an opportunistic infection, or if I see abnormal inflammation, if I generally know if my patients are HIV positive or HIV negative, it's right there on their medical records. So if they're HIV positive, then I'll know to look straight at their labs. I have everybody's labs. So I look at their labs, I look for abnormalities and go from there. And I talk to their doctor. I can actually literally walk down the hall and see their doctor. So if I ever find anything abnormal like that, that's kind of like where I shoot to. But I mean, I'm atypical in my environment there. But it's is this an immunosuppression thing, or is this something else? Maybe it's more diet related. Maybe it's more, it's just stress related. And so, I mean, it's in the end, it's not a different process. I just have a different starting point, if that makes any sense.
Yep. And JoAnn, I know you're teaching. Anything that you would recommend your students to change?
I think for my students, I always try to ask them to see their patient as a person and not a blood value or a disease state. And I think that, students sometimes are afraid of patients that have a disease. And so I try to make them recognize that they're working with a person, not a disease, and that they want to see their person as having goals and desires and dreams like everybody else. And they're not going to die because they have HIV. They're going to die from something else or because of something else. They're not going to die in their chair, and it's not a life sentence. And it's all, let's not dramatize what they have, because as Amber just said, we could worry about somebody having cardiovascular disease or diabetes or so many other things. Patients, every person is worth all of our time and attention. They can be fragile or not. And how we view our patients is really important. But the one mistake we don't want to make is to think that they're a disease. They're a person, and we want to respect them as a person, and we want to value them. And so while I said in the beginning, I teach pathology and I love pathology and I get excited about pus, it doesn't mean that I look at my patients and say, I can't wait to treat your disease. What I want to do is prevent disease, and I want to make sure my patients are as healthy as possible. So that's my goal. And remember, every person deserves our very best.
Thank you. That was a very well said.
Excellent.
Great ending to this. I really hope that everybody took some really great information from this. I know I definitely did. But what I really kept hearing a lot of is moving away from the stigma, treating the patient as an individual, really delving into that medical history, maybe looking at it a little bit differently than you may have in the past. And I love that you guys also brought up something that Daniel and I had a conversation about. I don't know if you remember this in Uganda, but when we were having, we had these, young pre-med, pre-something students that were on this trip with us. And we were both like, yeah, I'd take an HIV patient over a diabetic patient every day of the week because
stability.
So right. You don't know if that cardiovascular patient's going to have a stroke right there in your chair. And a lot of times those patients who have HIV and are on these antiviral meds are way healthier than my diabetic cardiovascular and just the random person that might be sitting in my chair at that moment. So I think that's something that we definitely need to keep in mind, and that there is no changes to our infection control procedures and how we would help take care of that patient. And I hope everybody hears that and it sits in your head and never goes away. So thank you guys so much for taking the time, for doing the work ahead of this and bringing some really great, interesting articles. And I will have all of your information in our show notes. So if somebody needs to reach out and wants to talk to you more, that will be there. But thank you again so much. I appreciate you guys.
Thank you.
Thank you.
Thank you, Michelle.
We hope you really enjoyed that roundtable, and be sure to check out PDT Dental. Head over to their website, Paradise Dental Technologies, and if you're on the show floor, going to trade shows, go see them. Check them out. They're great, great people.
And a special thank you to the guests that were on this episode. Feel free to reach out to them as well. They have a lot of good information for you, and they like to be contacted. So you'll see their information in the show notes.
And be sure to follow us on Instagram or Facebook. You're welcome to send us messages through either of those social media platforms. And you can send us a message at a tale of two hygienist @gmail.com. You can even email us directly, either Michelle at a tale of two hygienist.com or Andrew at a tale of two hygienist.com. And head over to our website and subscribe to our newsletter, a tale of two hygienist.com.
There's a theme going on there if you haven't been able to tell. And also, we're always looking for ideas for student roundtables. So if you're a student and you have a specific topic you want us to tackle, please reach out to us. Let us know.
We appreciate you for listening, and we hope you have a great week.
Bye, everyone.
Bye, y'all.